of pregnancy. The talk is divided into the following sections. I start with an introduction, followed then by the indirect cranial markers on sagittal imaging, indirect cranial markers on axial imaging, and then direct imaging of the spine, followed by differential diagnosis and some summary and concluding comments. We all know at the mid-trimester that examination of the posterior cranial fossa for the banana-shaped cerebellum and lemon-shaped head leads to the diagnosis of spina bifida. In fact, these two indirect markers identify 95% of open spina bifida. In some, there will be secondary changes of ventriculomegaly and talipes. In the first trimester, many years ago, Rabbi Shawi reported on examining the posterior cranial fossa in the first trimester of pregnancy by identifying no fluid in the fourth ventricle in 100% of cases, absence of fluid in the fourth ventricle, or absence of the intracranial translucency. We subsequently learned that in fact the posterior cranial fossa or absence of fluid in the fourth ventricle is only present in a minority of cases. But in fact it's the changes in the midbrain and the brainstem that are more likely to lead to a diagnosis of spina bifida in the first trimester of pregnancy. Posterior displacement appreciated on axial imaging, posterior displacement appreciated on sagittal imaging. So to simplify things, and one of my concluding remarks from today's talks is that going forward in thinking about spina bifida in the first trimester of pregnancy, we need to think of it very differently from the second trimester. The answer lies in the posterior cranial fossa in the second trimester. In the first trimester, the answer lies predominantly in the midbrain on axial imaging and in the brainstem on sagittal imaging. In fact, when you go back to Rabbi's original study, years later, the same group in a multi-center study noted that the intracranial translucency was absent in only 18% of cases. There's been a swagger of many different markers that have been described since. It's such a confusing area. Over 15 different indirect markers suggesting or leading us to identifying a defect in the fetal spine. What I'm going to do today is to hopefully simplify this when I come to my concluding slides. But I would like to walk through these indirect markers because some of these you will find are helpful and are exceptions to the rule in certain circumstances. But I also want to just say a few words as to why are things so different? Why is it that it's so challenging in the first trimester of pregnancy and so easy in the second trimester by comparison? I think, first of all, it's an abnormality that presents with a wide spectrum of findings. It's an abnormality that changes over time. And the exact time frame when these changes occur in the posterior, midbrain, and brainstem is the time when we are screening for Down syndrome at 11 to 14 weeks of gestation. CSF leaks from the defect in the spine. The brainstem shifts posteriorly and inferiorly. Fluid continues to leak. The lateral ventricles dry up. So does the third ventricle and the aqueduct of Sylvius. And the cisterna magna dries up. The intracranial translucency reduces in size, further fluid leaks, the intracranial translucency disappears, further fluid leaks, the BPD reduces, further fluid leaks, the Arnold-Chiari malformation occurs with obstruction to flow of CSF, and then as we head towards the second trimester, ventriculomegaly evolves. You end up with a situation where it shifts from the dry brain to ventriculomegaly at the mid-trimester. In fact, midbrain shift is not even evident at the second trimester of pregnancy. So there are a whole series of changes that occur on sagittal and axial imaging of the brain, and all depends where you perform your scan across this 3 to 4 week period. And that's in a sense why it's so difficult. Now let me show you. These are two video clips from the same patient scanned weeks apart with spina bifida. If you look in the bottom left-hand corner, you see that the brainstem is widened. And you can see that the distance between the brainstem and the occipital bone is reduced. These are very striking findings that you're seeing in this fetus. And weeks later, if you look at the same fetus, you see the brainstem doesn't look so wide, the displacement doesn't look obvious, the distance between the brainstem and the occipital bone is normal. And the width of the brainstem is normal compared to the thickness of the brainstem here. So it all depends as to when you perform your scan, as to what are the findings that you are going to see. So to simplify things, what I've done is divided into what I call primary findings and secondary signs. So the primary findings, if we look at it, it relates to the brainstem on sagittal imaging. And diagrammatically represented is what happens here is the brainstem shifts posteriorly and inferiorly, with secondary obliteration of the intracranial translucency sternum magna. But the striking finding relates to the brainstem being wide and the distance between the brainstem and the occipital bone reduced. All the data to date since the initial publication supports these two key markers as being strong markers for spina bifida and sagittal imaging. In contrast, in the midbrain, an axial section is what shifts posteriorly. So in axial imaging, you are all familiar with what a BPD looks like, 12 to 13 weeks of gestation. And what happens is this whole midbrain area and the aqueduct is displaced posteriorly. The other findings, I describe these as secondary findings, and I'll come back to what I mean by that later in the talk. So it's important going forward tomorrow morning in knowing what the normal anatomy looks like. So if we take a four-section analysis of the fetal brain, we see the midline falx. There's a good amount of fluid inside the lateral ventricles. The cavum velum is present. There's fluid in the aqueduct, it's reassuring. The distance between the aqueduct and the occipital bone is normal, around 5 millimeters. And we can see fluid in the fourth ventricle, and we can see the choroid lining the roof of the fourth ventricle. These findings that we're seeing all reassures us that this fetus does not have spina bifida. And I'll come to detail this a little bit more in the next few slides. In sagittal imaging, we need to know what the normal brain looks like. There are three black spaces. So the first is the brain stem, which is the largest. The second is the intracranial translucency, which is the intermediate. And the third is the sternum magna. So from a practical point of view of screening, just understand as a minimum these three black spaces of decreasing order in size. All right, so I next want to move to sagittal markers of spina bifida, and I'm going to start by enumerating these markers. Number one, the intracranial translucency here is normal. It disappears in spina bifida. The brainstem has got normal thickness. It's enlarged in spina bifida. The distance between the brainstem and the occipital bone is reduced in spina bifida. The ratio between the brainstem and the brainstem occipital diameter is greater than 1. The cisterna magna, which is this fluid-filled space, disappears in spina bifida. And the frontomaxillary facial angle, which is quite a subtle finding, is reduced. This is normal, and this is a fetus with spina bifida. So I've described the three black spaces, but I also need to go through the lines. So this is the anterior border of the brainstem, the posterior border of the brainstem, the roof of the fourth ventricle, the occiput, and the two lines of the nuchal fluid, that borders nuchal fluid. The spaces of the brainstem, the intracranial translucency of fourth ventricle, the cisterna magna, and the fluid of the nuchal translucency. You need to know your lines and your spaces. You can see it's quite complicated, and there is a learning curve and understand these anatomical landmarks or sonographic landmarks in screening for spina bifida. Now I'm going to show you two cases and ask you which case is normal and which case is abnormal, having described what the changes are that occur in spina bifida. And let me help you out, because here we are looking at the brainstem, the fourth ventricle, and the cisterna magna at 13 weeks of gestation. When we come to look at this case, we can see a brainstem that looks a lot wider when compared to this brainstem here. And also we can't see a fourth ventricle or a cisterna magna. When we look and draw a line along the upper border of the hard palate and the sphenoid bone, and we draw a line continuing to the occiput, that the junction between the thalamus and the cerebral peduncle is below this line, another useful marker. In contrast, look at the normal fetus over the hard palate. This is the sphenoid bone, continues the occipital bone. The junction lies above the maxillo-occipital line. I'll come back to why this is important later. Now, another example. I'm going to show you two clips and ask you which case is abnormal. First of all, you appreciate that this is the brainstem and the fourth ventricle, cisterna magna. And in this case, you see that you have the thalamus, the midbrain, the cerebral peduncle are displaced so low in this case. There's no visible fourth ventricle, no visible cisterna magna. And when you draw a line over the alveolar ridge to the sphenoid bone, you can see the thalamus is almost below this line. And certainly the junction is below this line. Now let me show you these two cases, one at 12 weeks and 5 days and 13 weeks and 2 days, and which case is abnormal. So when we look at this case here, we see a prominent brainstem, but there is a fourth ventricle present, and so is there a cisterna magna. When we look at this case here, we can see the brainstem to the occipital bone distance is normal. Both of these cases are cases of spina bifida. So while the first two are straightforward and easy to demonstrate to you, these cases are far more challenging. If you use drawing the line from the tip of the maxilla over the sphenoid bone, you can see the junction between the two lies below. That's helpful here. Similar, if you draw a line here over the alveolar ridge, the sphenoid bone, and keep going to the occiput, you can see the junction falls below this line. But at the end of the day, these are all very subtle markers. So what I'm going to do for you is simply run through 12 cases of spina bifida. And in the luxury of time, when you go back and review this lecture, you can appreciate how subtle these changes are. You can appreciate in how many cases the fourth ventricle is visualized and is present. You will appreciate that you're far more reliant on seeing the wide brainstem and the reduction in the distance between the brainstem and the occipital bone in screening for spina bifida. Okay, let's move away from sagittal markers now to axial markers of the fetal brain. So I just simply, like I did for sagittal, just list them all one by one. In the normal left-hand side, normal volume of fluid in the lateral ventricles, dry brain in spina bifida. Cavum velum interpositum disappears in spina bifida. When you look at the ratio between the cord plexus area and the head area, this is significantly abnormal in spina bifida. When you look at the aqueduct of Sylvius, this is also abnormal in spina bifida. This disappears the fluid. When you look at the distance between the posterior border of the aqueduct and the inner border of the occipital bone, that reduces. When you look at the parallelism of the cerebral peduncles demonstrated here, and then as you head towards 14 weeks, you then begin to see the banana-shaped cerebellum. So what I'm going to do now is to go through the axial sections of the brain and draw for you what happens in spina bifida. And when we look at this, we can see the aqueduct of Sylvius, which is here, and this is the cerebral peduncles and the thalamus. This whole area is displaced posteriorly, and we first reported this back in 2011. When it displaces posteriorly, you also note that the aqueduct decreases in size. So this displacement of the midbrain that's seen in axial section was reported 8 years prior to the crash sign. I think the lesson learned from this study at our unit was that we should have come up with a sexier name than the aqueduct of Sylvius, a sonographic landmark on neural tube defects in the first trimester. Not only did we report the crash sign 8 years before it was described, but we actually quantified the degree of the crash by the distance between the aqueduct of Sylvius and the occipital bone. I'm going to show you the exact same graphics and then match this with what happens with sonographically. The advantage of looking at this approach is that we all know what a BPD looks like at 12 to 13 weeks. The learning curve for this is much quicker than learning all the lines and spaces on sagittal imaging. Now let me show you a case of two cases and ask you which case is abnormal. So when you look at this case, you see straight away as you sweep across, you appreciate that displacement of the midbrain sitting juxtaposed as to this aqueduct, which is a good distance away. You magnify the image and you come around and look at the aqueduct of Sylvius. And as you do so, the mean distance between the posterior border of the aqueduct of Sylvius and the inner border of the occipital bone is the order of 5 millimeters. In this case here, when you look at it, you can see that it's just sitting juxtaposed, and you can see there's very little fluid in the aqueduct of Sylvius. Now let me show you a 4-quadrant analysis in 2 cases and ask you which is abnormal. The first thing you recognize in the top left-hand corner, there's very little fluid inside the lateral ventricle. Compare that to here, which is normal. The cavum velum interpositum is not visualized. The aqueduct of Sylvius has no fluid. The aqueduct, the cerebral peduncles are displaced, so the distance between the posterior border of the aqueduct and the inner border of the occipital bone is significantly reduced. It's just a fraction of a millimeter. And there's no fluid visible in the cerebral fourth ventricle. So like I did for sagittal section, I'm going to show you 12 cases, and when you look at all of these, you can see how simple this approach is, because you're looking at a BPD. And everybody in the room today knows what a BPD looks like. You know that the BPD should be placed at this point here and not sit in the region of the posterior cranial fossa. That posterior displacement becomes almost immediate appreciation when you understand the importance of the distance between the aqueduct and the occipital bone. So now I put these two cases side by side and I ask you which strikes you more. In this case, you can see that there's a wide brain stem, but we do have an intracranial translucent, we do have a cisterna magna, and the distance between the occipital bone and the posterior border of the brainstem is reduced, but it's subtle. Whereas you look in the axial section, it's striking that you've got midbrain displacement. I'm not saying that one is better than the other. I'm just saying that they are complementary, but they're looking at an area in the brain that is not the posterior cranial fossa that gives you the clue as to what's going on. The maxillo-occipital line is another marker which we described. You look at the tip of the maxilla, draw it over the sphenoid bone, and the junction between the thalamus and the cerebral peduncles, which is this point here, lies above that line. Similarly, in this case here, if you look at it with spina bifida, the junction between the thalamus and the cerebral peduncles lies below this line. After a while, you don't need to draw the line, just simply subjectively look at it and you can appreciate that displacement of the thalamus posteriorly and inferiorly. It's a very useful marker which you may add to your armamentarium in screening for spina bifida. This is just showing it in action, a fetus with spina bifida, and then this is drawing the line to appreciate it. Another example here showing spina bifida, and then towards the end of the clip, just drawing the line, you can see it falls below that line. It's a very simple approach in screening for spina bifida when you get used to knowing the landmarks. Again, the line does not necessarily have to be drawn along the entire length of it, just catch the tip of the anterior border of the maxilla and the sphenoid bone. Sometimes it's hard to get the full length of the upper border and the sphenoid in view. What does the published literature say about all of this? And I think if you look at it, it is clear from the published data that the strength lies in the midbrain and the brainstem in screening for spina bifida. And if you look most recently in one of the largest single-center prospective studies, which is recent in 2023, that the axial and sagittal images, when they're compared looking at the midbrain and brainstem, their accuracy or sensitivity is just as good as each other. This is the similar multi-center retrospective study which we had published from our unit back in 2020. So now let's move to examination of the fetal spine. You will find in about 30% of fetuses with spina bifida that by direct imaging of the fetal spine that you will pick up the abnormality. You don't need to rely on the cranial markers. This is not a difficult diagnosis to make. A large lumbar sacral meningomyelocele at 13 weeks and 2 days. I think most would identify this, particularly if you routinely perform an endovaginal scan. This with the 5 to 9 intracavity transducer. But it does become more challenging, and this is a tiny sacral spina bifida. I can't begin to tell you how long it took me to reach this point where I captured this short cine clip with the fetal sacrum right up against the uterine wall. But you see how subtle this defect is. In this case, it becomes even more subtle. At 12 weeks and 5 days, there's no visible defect in this fetus with spina bifida. Yet all the head signs were there. So what would you do if you were faced with 12 weeks and 5 days where the indirect markers were there and you couldn't confirm by direct imaging of the spine? Well, the answer to that question is you bring the patient back, because the indirect markers are not a diagnosis. The diagnosis has to be made in demonstrating a defect in the spine. So that's exactly what we did on the 16th of July. We brought the patient back on the 23rd of July, 1 week later. Now look at the difference of what you're seeing. This was using 3D with multiplanar analysis, and where you're focusing on is on the skin line. The kidneys come into view on either side, and as you focus down, you see a breach in the skin at this point here. This is the open spina bifida. But do you see how subtle that is when you do a multiplanar and compare it on both the A and the B plane? It is so subtle. But it's a reliance on that axial imaging that demonstrated that a spina bifida, then a call or definitive diagnosis was made. Also, you will note that in this fetus at 13 weeks and 5 days, that the banana-shaped cerebellum has now become evident, which gives you an additional reassurance on certainty of diagnosis. Again, as you reach the end of the 13th week and into the 14th week, in some you will see the second trimester findings. If you look at this case here, another example where you can see that there is fluid inside the lateral ventricles, it's not dry. The cavum velum interpositum is not visualized. But when you come back to the midbrain, you see the midbrain is juxtaposed to the occipital bone, and there's no fluid in the aqueduct of Sylvius. And when you come to that point of measuring the distance between the aqueduct of Sylvius and the occipital bone, it's a fraction of a millimeter. Similarly, in this fetus, the skin line appears intact in this case. This just shows you how challenging these cases will be. If you are ever in doubt, then bring the patient back where you can give absolute certainty about the defect in the spine. That's a very important point. Similarly, if you ever see a cystic lesion at the base of the spine, don't jump to a diagnosis of spina bifida, especially if the head signs are entirely normal. This is a fetus with a loop of cord that simply surrounds the back, and 3D volume analysis editing can show you the loop of cord. This is not spina bifida. In this case here, in a 3D surface rendered image here, you can see there is not only a loop of cord, which is an incidental finding, this fetus also has a spina bifida, a lumbar sacral meningomyelocele, of which 80% of fetuses of spina bifida occur in this region. I want to also say a few words about spina bifida at the pre and IPT scan, because we are routinely offering a transvaginal scan before drawing blood for cell-free DNA. At this instance, you can't rely, in a sense, on the midbrain shift, because every fetus has midbrain shift at this stage in gestation. When I say midbrain shift, the aqueduct of Sylvius sits juxtaposed the occipital membrane. When you look on this surface rendered image here, you can see the neural elements inside this 10-week fetus with spina bifida. And you can also appreciate it by looking on coronal imaging and an axial imaging here of the lumbar sacral spine in a fetus with open spina bifida pre-NIPT. An even more subtle case here at 10 weeks of gestation, where you can see the defect in the fetal skin in the lumbar sacral region in a fetus that has a physiological herniation and a dilated loop of bowel. You sweep up here, you can see to the fetal head that also the aqueduct of Sylvius is empty. There's no fluid. And I made the comment in the live scan about how the aqueduct of Sylvius is proportionately larger at 10 weeks, reference to the size of the fetal head. And not only that, but there's no fluid in the cerebral fourth ventricle in this case, and this is proportionately larger at 10 weeks. This also, when you looked at the sagittal imaging and the rendered image of this fetus at 10 weeks of gestation, there was no signs of a spina bifida, and this patient could not come back any earlier than 16 weeks and 5 days, but it just shows you the follow-up examination where the confirmation was made with the banana-shaped cerebellum. So let's then move on to differential diagnosis. In this case, at 14 weeks and 2 days, you can see a cystic lesion arising from the base of the spine. I don't think anybody would struggle with this differential diagnosis because there are quite significant solid elements within this cystic lesion arising from the sacrum. In contrast, in this case, it's a little bit more subtle, where you see a cystic lesion arising from the sacrum. There are no solid elements. On sagittal imaging, you see the cystic lesion with no neural elements extending into it. And again, this is back in 2011 when we reported the midbrain displacement on axial imaging. The midbrain was normal. So was the aqueduct of Sylvius. And the distance between the aqueduct of Sylvius and the occipital bone was 5 millimeters, which is the mean measurement. This is a surface rendered image of the same fetus showing the lesion arising from the sacrum. Bringing this patient back at the mid-trimester, you can see a normal posterior cranial fossa, and this is the cystic lesion arising from the base of the spine, a cystic sacrococcygeal teratoma at the mid-trimester. Last but not least, closed spina bifida in the first trimester of pregnancy is rare. In this case, you see wide separation of the ossification centers here with exposure of the neural elements, but you can see on axial and on sagittal imaging overlying fetal skin. It was over a large area of the lumbar sacral spine in a patient with large BMI, and these are the images of sagittal dissection of the fetal head and brain. If you look towards the end of the clip, you can appreciate that there is widening of the brainstem, and there is also a reduction in the brainstem to occipital bone distance. The intracranial translucency was normal. So in summary, I accept that the diagnosis of spina bifida in the first trimester of pregnancy is challenging. We are measuring tiny spaces, looking at tiny lines. I think, however, we can simplify it. We can simplify it by looking in the axial section for evidence of midbrain shift. And on sagittal imaging, we can look for evidence of brainstem enlargement and brainstem shift. I think combining these two markers are the most powerful markers that we can glean from the published data. I don't deny that the other 14 markers, which I've labeled in different colors below, have no role to play. They do, they have a significant role, but it's a matter of weighting which markers you wish to use in routine clinical practice, because at the moment there is no international protocol, there is no standardization by which of any of these markers we should use in routine clinical practice. And what I share with you is simply an experience of what we found to be the most powerful markers supported by what's in the published literature. You may ask, why on earth am I showing you the table from our paper back in 2011, which described for the first time in axial imaging the crash sign? The reason I'm showing it to you is while this appeared 8 years before the crash sign, it not only described the subjective appearance of the crash, it actually objectively measured the distance between the posterior border of the aqueduct of Sylvius to the inner border of the occipital bone. And the reason I'm showing you is I want you to look at these figures, because when you look at what is the mean and the two standard deviations, you can actually catch the car as it's on its way to crashing, in the middle of the crash, and having completed its crash. In other words, you can gauge the distance between the posterior border of the midbrain and see how close it is to the occipital bone. I can make it even easier for you when you go to work on Monday morning. Every one of you on this webinar knows what a BPD looks like at 13 weeks gestation, because that's the time where most of you are doing your anatomy. You will find on average the distance between the posterior border of the aqueduct of Sylvius to the inner border of the occipital bone is 4 to 5 millimeters. But if you go to work and find that this distance is around 1 to 2 millimeters or less, the odds are you're looking at a fetus with spina bifida. Honestly, how easy is that when you know all these landmarks in routine imaging and taking a BPD in the first semester of pregnancy? I might stop there. Thank you.